Network and the California Healthcare Foundation. And I would very much like to welcome you to our webinar this month on harnessing the power of data to treat the individual. I know folks may be continuing to dial in, so I'm just going to go through a little bit of webinar etiquette and how we run these calls for folks. So first of all, just to be aware that this session will be recorded, and because of that, all of you as attendees are actually going to be muted as you come onto the call. Our little etiquette notes that is just mostly a reminder to everyone when you're on a webinar about kind of silencing the background noise, not putting your call on your phone on hold, etc. Will not be as important because I get to override everything and mute. But this is in particular if we decide to unmute everyone and allow people to ask questions directly, these rules about just being mindful that you're on the phone with a lot of other people really come into play. So if you have any logistic questions or questions in general, we really encourage you to use the chat function, which is in the lower right-hand side of your screen. You should see a little blue bar that says chat, and under there you can see the history of chat. You should see a message from me about waiting for folks to join the call. You can then note who your message should go to, and we encourage you to send it to all participants if it's a question for the speakers. Again, if it's a logistic question, you can use that drop-down memo and send a message directly to the host who can help you troubleshoot any issues you might have with the webinar. You also have above that chat bar a little hand icon, which you can click on and that will raise your hand. If you can see a phone next to your name, a little phone icon, that means I can unmute you. If you don't have a phone next to your name, it means that you didn't dial in associated with your name and I can't identify you to unmute you, and so you have to send in your question via chat. I hope that makes sense. It's a little bit complicated, but not really. So I'm going to briefly introduce today's speakers. We have, first of all, Dr. Peter Alprin, who is the Vice President of Medicine and Products at Archimedes, a healthcare modeling company that's based here in San Francisco in the Bay Area. There, he's responsible for developing and implementing analytic simulation tools with industry clients. Sounds a little geeky, but it does actually turn out to be clinically relevant. So these tools include the Arches Healthcare Simulator and Indigo, which is this individualized guideline tool used by providers at the point of care and which we're going to focus on this afternoon. Prior to Archimedes, Pete was the Director of Medical Informatics at Brown and Tolan Medical Group in San Francisco, where he led the building and rollout of their EHR and data analytics services, a task that many of you know was not an easy one. Before this, he worked as a product manager at Hippocrates, the leading provider of mobile handheld health information. Peter received his medical degree from the University of Texas Southwestern Medical School and still practices at the VA Medical Center in San Francisco. Following him will be Dr. Patrick Herson, who is a board-certified family doctor and an honors graduate of the University of Chicago Pritzker School of Medicine. After completing his training in Santa Rosa, California, so we still have a California bent here, he worked for 8 years at Central Minnesota Group Health Plan, which is a staff model HMO in St. Cloud. In 1999, he left St. Cloud to practice, teach, and help lead managed care activities at the Dartmouth-Hitchcock Medical Center and Dartmouth Medical School. And while there, he earned his MS in Evaluative Clinical Sciences with an emphasis in quality improvement, something that we are all working on hard here. Since 2003, Herson worked in full-time administrative roles with 2 insurance companies until January of 2010, when he joined the Fairview Medical Group in Minneapolis, Minnesota. And for those of you who are not familiar with the Fairview Group, they're quite impressive, and you'll hear a little bit more about them. And at Fairview, Herson is the Executive Medical Director for the South Region, and and just for clarification, the Fairview Group is an integrated multi-specialty group practice with over 40 primary care sites, in addition to employing hospitalists who staff 5 hospitals and a geriatrics team that staffs over 25 facilities and 7 transitional care units. So they're a pretty large system. So on that note, I am going to pass the ball. Well, first I'm going to advance the slides. I'm going to pass the ball on to Pete and let him tell you a lot more about the Archimedes Indigo product and approach.
Thanks very much, Sophia. I very much appreciate the kind words. First, I'd like to welcome everybody to the webinar. I'm doing this, as Sophia mentioned, with Patrick Herson, who's the Executive Medical Director of the South Region at the Fairview Medical Group in Minnesota. During my portion of the talk, I'm going to be focusing on the tool that Patrick and his team and his clinic are in the process of piloting right now. And this tool is called Indigo, which is a tool to improve healthcare quality and reduce costs. So first I'm going to tell you a little bit about Archimedes as a company, very briefly, and then I'm going to talk about the tool and show you some demonstration screenshots of what the tool looks like and then how it's used. So first off, let me tell you a little bit about Archimedes. So Archimedes is a healthcare modeling company, and as Sophia mentioned, it's headquartered in San Francisco. We were originally, the technology that Archimedes has developed is called the Archimedes Model, and I'm not going to go into a lot of detail about the model today because it would take up the bulk of the time, but I can tell you that it's a carefully validated mathematical model of human physiology, disease, interventions, in the healthcare system. The model has been in development since 1993, and our founder, Dr. David Eddy, originally did most of his work inside of Kaiser Permanente. But in 2006, we were spun out as an independent company, and we're an independent organization with our owner being Kaiser Permanente. So Kaiser is still very involved in our development and funding. So the brief word about the Archimedes model, and again, this will be as detailed and hopefully as geeky as I have to be during the talk. The Archimedes model, from which the Indigo guideline tool has been developed and extracted from, is a simulation model, as I mentioned before. And what's important to think about in our model is that it includes a wide range of variables that relate to a variety of conditions. And what we've done is we've incorporated risk factors and other variables that relate to diabetes, cardiovascular disease, cancer, renal disease, and a variety of other diseases into a series of equations which allow us to do simulations so that we can better understand how a person's life may progress under a variety of circumstances. So in essence, what we do is we build equations which help represent physiologic pathways. And what we mean by physiology are really the risk factors that I think most of the people on the phone here understand that to be the ones that they think about when you think about taking care of patients, things like LDL and systolic blood pressure, et cetera. The model contains multiple conditions. It includes coronary artery disease, diabetes and its complications, stroke, hypertension. We have obesity in the model through our biomarkers. We have cancers of the breast, colon, and lung that are involved in our model, and we also have modeled asthma. So what's important is that the model broadens a broad range of diseases as well as includes a variety of interventions that we can test and simulate the effect of on our virtual people. And importantly, and I'm also not going to have time to go into this in great detail, but the model's been validated against many, many clinical trials to help prove to ourselves and others that the model's results are accurate and useful. So, at Archimedes, as we developed our model, we thought long and hard about how we could take the power of our model and bring it to the point of care, bring it to a very useful clinical application with healthcare providers and healthcare systems. And really, if you think about it, our Indigo tool is a tool that is focused on improving the content of care. And what we mean by the content of care is what doctors do, the decisions that they make when they are treating patients. And today, the content of care is largely determined by clinical guidelines, at least certainly for the major chronic illnesses. I mean, obviously, there's a lot of things that we do which there's not clinical guidelines, but by and large, we try to follow them if, in fact, that they've been developed. The issue, though, is that current guidelines do have certain limitations just inherent in the way that they're designed. In general, guidelines tend to focus on one variable at a time. So things like there'll be a blood pressure guideline for hypertension or a cholesterol guideline for, looking at ATP3. And they also use very sharp cutoff points in defining disease or disorders in diseases in which the biomarkers themselves are continuous in nature. So it sort of ignores the nature of a lot of the risk factors that we're treating every day. So an example of this, as I mentioned before, would be the National Guideline for Hypertension, which dichotomizes or cuts off and creates guidelines and thresholds for treatment. But it's our contention that it's possible to design more effective guidelines that can take into account more information and thereby improve quality as well as lower cost, and lowering costs by being able to focus on the patients who would need interventions the most, i.e. gain the most benefit. So here's an example that I like to use that talks about the oversimplification, but in a real explicit format. Here we have two patients. One is Mrs. Smith and the other is Mr. Jones. And if you look at Mrs. Smith and Mr. Jones, these are pretty typical patients that a primary care physician certainly would need to take care of or think about taking care of. And if you look at them, they're both, they both have issues in their own special way. And Mrs. Smith is overweight, but not quite as overweight as Mr. Jones. She has a slightly elevated blood pressure of 142. Mr. Jones's blood pressure is not quite 140, but he has a higher LDL and a fasting plasma glucose that's higher, et cetera. So if you were to apply the JNC7 guidelines, the current guidelines for the treatment of hypertension, what's interesting is that who would they recommend for treatment? Well, in fact, Mrs. Smith would be recommended for treatment. But if you were to take these patients and you were to calculate what their 5-year risk of a heart attack or stroke would be, which are the two things that you're really going after when you treat hypertension, you would find that Mr. Jones has about a 6-time higher risk than Mrs. Smith, and thereby would very likely gain a lot more benefit if you were to aggressively treat his blood pressure as opposed to Mrs. Smith. Now, I know there's a lot of physicians or other healthcare providers on the phone who might think that, well, Mr. Jones, I'd bring him back and I'd check his blood pressure. But thinking about all the patients that we need to treat in our very large and complicated healthcare systems, this may be the only opportunity you have to reach out and actually touch Mr. Jones when he's in your office. So it's important to really think about as much as you can when the patient is in your office for that precious 15 minutes. So how is it that we can help? Well, in designing Indigo, what we've done is we've designed an analytic tool that takes into account much more, a wider array of information in calculating and determining who it is that you should target for treatment. So we take into account a wider variety of personal health information that's largely available in today's electronic health records. We then will calculate the risk of a variety of different health outcomes, and I'll show you those in a few minutes, using the Archimedes model and the derivative equations that we've put into the Indigo tool so that it runs instantaneously. We then will calculate the effect of potential treatments on those risks, and that's really one of the most important things that I'd like to get across. Our tool not only assesses the 5-year risk of a person or whatever time horizon you're interested in, but it then will simulate the benefit that a patient would receive if you were to try a variety of different interventions. And those interventions include medications and behavioral changes, so that you can not just identify your patients at highest risk, but you can evaluate the patients and rank the patients by the patients who have the most available benefit from treatment. So these are patients who are actionable today and immediately. And that's a really important point for those of you out there who are trying to think about how to best take care of your populations. The tool and the algorithms calculate and incorporate the side effects of interventions, so we take those into account. And it also is useful that we're able to combine multiple outcomes effects into a single benefit for each patient, so that we can come up with a single unified score to help you determine who you would like to target for treatment. And as a patient, you can help think about which interventions are going to be the most important for all the health problems you have, not just for one or the other. Indigo can be used in a variety of different ways, and I'm going to talk about those in a few slides, but it can help identify patients who would benefit from treatment but don't necessarily meet the current guidelines for treatment and thresholds. It can allow you to rank interventions. Therefore, if a patient has a variety of interventions that they would be eligible for, you can use the tool to help prioritize those interventions within a single patient that is specifically tailored to their particular circumstance. And then you can also use the tool to particularly educate patients on the benefit of treatment. This was one of the most exciting things we found in a pilot that we did that I'm going to share with you in a little bit, but that the tool itself actually helped patients adhere better to the medication recommendations and behavioral change recommendations that their patients and their physicians recommended for them. The tool itself has been integrated with a variety of different electronic health record and other data systems. It can be easily integrated with electronic health records or chronic disease registry systems. And our pilot implementation with Kaiser, we integrated the tool with their chronic disease registry tool. The tool has been integrated into Epic, and this is how it's being used in the Fairview pilot, and I'll let Patrick talk about that a little bit more. And we have current ongoing conversations with some other electronic health record systems like Cerner and Allscripts. As I mentioned here, we have some examples of current and past integrations at the point of care with Epic, as I mentioned before, and we're also working on a patient portal with Kaiser Permanente so that patients would be able to access the tool directly from their patient portal. This is a quick display of the inputs of the current Indigo tool, and I'm not going to go into all of them, but it takes into account these general categories of interventions. We look at demographics like age and gender. We look at biomarkers. We look at behaviors such as smoking. We take into account medical history in calculating our risks. And importantly, we look at a patient's current medications, both current and ones they've taken in the past, to help assess the current risk of a variety of events. The tool also will account for allergies and contraindications. And an important point to note, I see there's a question that came up, is that the tool does integrate with HL7, so that it's a very flexible communication language, and we're able to integrate on a variety of different levels, but it's absolutely HL7 compatible. This is a more detailed list of the outputs of the current tool. So we calculate the risk of the health outcomes that are listed on the left-hand column. As you can see, cardiovascular disease, diabetes, complications, renal disease, and then the risk of cancers of the breast, colon, and lung. And then on the right are the lists of the interventions that we then simulate for these particular patients. So we calculate the benefits from statins, a variety of antihypertensives, as you can see, medical interventions, as well as certain behaviors like weight loss and smoking cessation. One thing that's important to note is that we are constantly able to add new interventions as we develop the tool, and we're also adding new diseases into the tool, so it becomes a more complete clinical decision support tool. This particular slide is probably Sophia asked us to try to avoid geeky, but this is probably the only really geeky slide in the whole deck. And what I like to point out is just in graphic form how it is sort of that Indigo does what it does as compared to, say, a guideline. And really what you have here on these two graphs is risk is the vertical axis, and then your proxy for risk is on the horizontal axis. In this case, it's LDL. So if you think about it, ATP3, the cholesterol guideline, uses LDL and the level of LDL as a proxy for the risk of someone's risk of heart attack or stroke. Because as clinicians, we're treating these intermediate biomarkers so that we can prevent the ultimate health outcome. So in this case, what you would see is the blue dots. This is a real group of people that we've done our tool with. The people in the blue dots are the ones who would be identified for treatment. And what you can see is there's a lot of people in the upper left-hand corner who are not identified for treatment because their LDLs are too low, but actually by our calculations and calculations that have been validated against something like the Framingham risk score would show that those patients actually would derive a tremendous amount of benefit from having their cholesterol treated. Now, the Indigo tool, what it does is it actually sets the level of risk to whatever level you would like. So in this case, we set it to the risk that would allow us to achieve the same benefit that you would see in the ATP3 graph. But you can see we're able to identify patients in that upper left-hand corner. And that's really the sort of magic, i.e. those are the people who the Indigo tool would identify who the guidelines would, in essence, be falsely negative for. So I'm going to stop there, and hopefully everybody was able to follow that. The ways in which Indigo can be used, so as we think about workflow, which is, of course, where the rubber meets the road, you can use it before the visit, i.e. to think about setting priorities for different case or disease management programs, so setting priorities for which patients you should target with your precious resources. During the visit, you can use it at an individual patient level to help prioritize patient interventions for a particular patient or find risk patients who weren't identified by guidelines. And then after the visit, as I mentioned before, the tool tool seems to help patients with compliance by individualizing the information and really showing these patients exactly what the benefit would be for them, as opposed to a more generic message that comes with a guideline. So how the current tool is being deployed, I think, sort of reiterates some of these same messages. The tool is being used in the exam room by providers at the point of care, and that's where we've integrated into the EPIC system, and Patrick can talk more about that. We're also using the tool by care managers to prioritize care for the populations, and then, as I mentioned before, we're going to be deploying the tool for direct patient access on a website. It'll be, of course, tailored towards specific patient messaging as opposed to that being specific for a provider. Just before I go in and show you some screenshots of the tool, we did do an independent evaluation of a pilot that we did. So we first piloted the tool with Kaiser, and that pilot lasted 9 months. And here are some of the salient points. There's going to be a paper that's published on this at a future date. But some of the information that we gleaned from the trial is that patients who used the tool were more likely to be compliant with their physician recommendations than they were if the tool was not used during the patient visit. So that's a general finding. Now, this pilot was far from being a completely conclusive pilot at all. It was not a particularly large study, and it was not done for a significant amount of time, but at least the trends were in the right direction. We did see improved outcomes as compared to the control arm. There was a 13% reduction in 5-year cardiovascular risk by using the tool as compared to people who didn't have Indigo used during their visit. The physicians themselves had significant physician acceptance. They all found it easy to use, and the patients themselves were significantly engaged with the tool, which I think is demonstrated by that first bullet. So as our first pilot, certainly we got, the answers were in the right direction, and we're in the process of doing more analysis of the tool so we can have better information. But these were our first findings. So in terms of thinking about some of the reasons why the medication uptake and the patient compliance may have improved so significantly, these are anecdotal, but there were some comments about that the conversations with patients were different, that the personalized information was powerful. Really, most of these things focus on the fact that the information was tailored towards the specific patient as opposed to being a more generic message. And I think that's really important. So I'm going to move forward here. So this demo is just really a series of screenshots, and this is, I've got just a few more minutes left before I hand the ball over to Patrick. I'm going to walk you through a series of slides for the way the Indigo tool looks now and in the way that Patrick may be using it. The first thing that you see is a slide that pops up with all the different interventions for a particular patient. And what you can see down the left-hand side are a variety of those interventions. And then what you see on the right is the benefit score. I don't have time to go into how that's calculated, but suffice it to say that the higher the number, the more benefit that will accrue to the patient if they were to successfully implement that particular intervention. And I know a question people may have is, how do we calculate that? We do assume in our benefit that the patients will be compliant with the things that we give them, because this is really meant to be, from a patient perspective, a maximal potential benefit that they may get so that we can maximize their potential behavioral change. But then the patient, the physician or the assistant, prior to going into the exam room, can unclick or click some of these buttons to help tailor the following graphs to that specific patient. So if you know that your patient has told you that they won't start this medication, or they're not interested in stopping smoking, you can delete that from the tools that I'm going to show you, so that you don't even have that conversation at that visit. Because sometimes it's not good to have distracting things that you know the patient isn't interested in. So you unclick it. Then what you'll see is you'll come to a graph like this, and this is really the end of my presentation. But what you see here, and I'd like to, the first thing I want to focus your eyes on is the black bar. That shows the patient's 5-year risk of a heart attack or stroke over the next 5 years, and that is a 5-year risk. Then what you see on the red bar is if the patient were to stop what he's currently taking. So remember, the tool takes into account the medications that the patient is currently on, so that we're not going to recommend or come up with distracting recommendations for interventions that the patient is already using. Then what you have here on the blue is something called My Plan, which is really the combined benefit that the patient will receive if they were to try it and any one of the different interventions that are along the right-hand side. And I'll go into that very left-hand bar in just a second. But if I go forward, what you'll see is we can conceptually click one of these items here. If I click again, what you'll see is I've now clicked statin and smoking cessation, and the blue bar has decreased, meaning that the patient's risk has decreased if they were to take these two medications. And the patient, you can talk to the patient about the fact that their risk today has gone from where it is the top of the black bar down to the blue bar, roughly half. So this is a really useful tool during the physician-patient conversation or the nurse-patient conversation. And across the top here, you'll see a variety of different tabs where you can have these similar bars which are tailored towards those specific diseases. Now, in this patient, because this demo patient is a man, the breast cancer portion doesn't light up, and neither did the diabetes complications tab because this patient does not have diabetes. So the tool is intelligent and takes and only presents the information that's relevant to that particular patient. So as I continue to move forward, I'll be able to show you some of those things. I've now added yet another one, and you'll see that the blue bar has further decreased. This healthy bar all the way to the left is something that we added because we heard from a number of physicians that they have patients who are otherwise doing pretty well who want to try to do even better. And this healthy bar represents what the top 10th percentile of someone with their age and gender would have as a 5-year cardiovascular risk. So really something to strive for that really engaged patient. So we try to make the tool useful for the widest variety of possible patient types. This is just a demonstration of what your risk of diabetes, so showing that if you were to lose weight, your risk of diabetes would drop by about half in this particular patient. And then we also have colon cancer. So at this point, let's see here. I was going to hand the ball over to Patrick, so I'd like to thank you very much for listening, and I certainly will be on the line and ready for questions after Patrick has presented his portion of the webinar. Thank you so much.
Thank you, Pete. I believe you're handing the ball to me, right?
I am. I'm going to do that right now.
Cool.
There we go.
All right.
I've just done that.
Well, great. It's a pleasure to join you all today, and I hope you're all having a good day. And I always learn more, Pete, every time I hear your presentation, and you remind me why we're so excited about the work that we're doing with you. I want to briefly give a description of who my medical group is, some of the market pressures that have led us to the work with Archimedes, how it's been going so far, and then sort of further work that we have in mind. So the Fairview Medical Group, as Sophia noted in her introduction, we're located in the Minneapolis-St. Paul, Minnesota area. And we cover roughly about 8,000 square miles in a 7-county area. We're a multi-specialty group practice, but very heavy on the primary care side, probably 2/3 to 1/3 primary care to specialty care. We have 40 or more primary care clinics. We're opening a couple more this year. We have just about 500 total providers. That includes mid-level providers as well. And we had 1.5 million patient visits in the calendar year 2011. Some of the market pressures that we face here where we are is that we have a publicly reported quality program called the Minnesota Community Measurement. And I didn't put a link up there, but you can type that in, and it's a .org URL that on an annual basis presents on, I believe, now close to 30 quality indicators for all practices across Minnesota. So we've got quite a bit of transparency here with our data. Another interesting aspect of the market that we practice in is that 70% of all the physicians in Minnesota practice with in one of 11 integrated delivery systems in the state. So very concentrated into integrated multi-specialty group practices. And so we're constantly comparing ourselves and being compared by patients, by employers, by state regulators and such against one another on these publicly reported initiatives. And to give you just a small feeling of flavor, one of the more commonly looked up measures on the Minnesota Community Measurement website is the optimal diabetes score, which is around the optimal management of the 5 aspects of diabetes care. We have a statewide average in Minnesota of 18% of all patients hitting that. The Fairview Medical Group, we were just above 40% last year overall with optimal control of diabetes. Our best clinic performed at 59+%. And then one of the providers in that clinic actually had 70% of her diabetics, satisfying all of the diabetes pieces. So you can get a feel and a flavor for how the Indigo work can help us engage our patients to take further action when they're not adherent to our recommendations. We also have a disproportionate number of Fortune 500 companies headquartered in Minnesota, given our population, and they have banded together over time with a Business Healthcare Action Group. I know there's a fairly similar one based out on the West Coast. And they have been very assertive in pushing for more accountability from the insurance payers as well as the provider systems for outcomes, quality, and satisfaction. And so we have faced plenty of pressures to keep upping our game and defining and describing the value that we're bringing to our patients and the people paying for care. Some internal pressures that we face as a system is that as we've put a lot of focus on our quality improvement efforts, we've gotten quite a bit of appropriate pushback from our doctors and advanced practice providers, describing how they feel frequently cheated when we treat continuous physiological variables in a pass-fail mechanism. So I often will hear doctors say to me, this patient came to me, a new patient with a blood pressure of 196/166, or pick your diastolic that you want, and I got them down to 142/92, and they're a fail because the cutoff with the Minnesota community measurement work is 140/90, depending on the disease state and such. And so there's pushback from our providers rightfully about that. We also pay our primary care providers, 40% of their pay right now is based on their quality results. And so that certainly is putting pressure on them and their care teams to improve and increase the amount of quality that they're delivering to their patients. And one of the behaviors that we were beginning to see as we do a team care process we call a C3PO, which is a care team working on a disease registry for a particular provider or teamlet within a clinic. So they'll get on a monthly basis all of their diabetics who are quote-unquote failing on one or more of the 5 diabetes measures that make up the Minnesota community measurement work. And so then they have a chance as a team to decide who will address, whether it's just a need for better blood pressure control and we can have a nurse contact someone, or it's a need for a visit for a physician intervention, or if it's a matter of scheduling a lab follow-up, and so we'll have a secretary or a scheduler contact the patient for that. But one of the behaviors that we were observing during these meetings was people looking at a patient and saying, she's 0 for 5, meaning she's not meeting any of the 5 criteria, pass on her, and let's focus on the person who's passing on 4 out of 5, and maybe their blood pressure is 142/92, and it's a matter of upping a dose of an ACE to get them below that magic threshold. We're clearly, I think we all know, and certainly Pete with the Archimedes model can validate, we can bring much more benefit to the patient who's 0 for 5 with any number of interventions than we can with the person who's 4 for 5 and just making a small incremental improvement in their blood pressure. And so we wanted to find another way to begin to capture and quantify and describe for our providers a different way to think about triaging their patients and stratifying them. And then lastly, as we've begun our transition to more of a population-based care model and population-based financial models, we wanted to find savvier ways to begin to identify those patients that we can really have the greatest impact or make the biggest improvement for. And we think the Archimedes model will probably be the approach that we'll be using to do that. So as we've been making this transition, one of the pieces of corporate art that our CEO has sort of put together and speaks to a lot is, if you look at the top red circle here in this this virtuous cycle, is we needed to change the care, and we have really done quite a bit of work to redesign how primary care is delivered within our practice, and that would be a whole nother webinar on its own. But we have really focused on our care teams, changing provider behaviors, addressing cultural issues that have gotten in the way of really providing patient-centered care. That needed to be tied with changing the payment mechanisms. So right now, this month, Fairview was named as one of the 32 pioneer ACOs, and with that contribution, if you will, now of patients, we have about 65% of the patients attributed to the Fairview Medical Group are in some kind of a shared savings or risk-based payer contract. And then the final piece then in the cycle is we need to change the experience so that we can get our patients activated and engaged in addressing their healthcare needs and in changing their behaviors, which ultimately leads to a different care experience and lets us perform better under the different risk contracts that we have. And we clearly see that the Archimedes Indigo tool as a key resource in addressing our patient activation and our consumer engagement. We've also in this space have right now out of our 360,000 patients that are currently attributed to us, we have about 100,000 unique PAM scores, patient activation measure scores on that population, and we're beginning to do some analysis with the people up at the University of Oregon to begin to analyze our people who are more engaged. What's their quality look like? Are there correlations with that? Does it tie back to their utilization? Does it tie to their satisfaction? And how might the Archimedes tool being applied with people help to change that PAM score, help consumers feel more engaged and more empowered with their healthcare needs? So this slide here is really, I'm not going to go into it at all, but it really begins to demonstrate at a real high level a lot of the work that we've done looking at our workflows and clinical processes around changing how care is provided within our practice. And this is sort of more detail about how we've changed the payment. So we've got the shared savings contracts with the 4 local payers. We've got the Pioneer ACO work that we started here in January. And we've begun now for that last about third of our patients, full 20% of that 35% are in Medicaid. And we've begun a dialogue with the state to see what opportunities exist for us to have sharing risk contracts with them as well. And then changing the experience, so as I mentioned, we've got the Archimedes Indigo pilot in flight in 2 of our practices, and I'll describe that in a minute. We've begun to experiment with video visits to remove barriers for patients seeking care. We've got our PAM work. A big key part of changing our care model has been really focusing on care teams, fairly non-hierarchical ones, with distributed responsibility for ultimate results for the patients. We also just launched last week a product called Hypnosis, which is a web-based acute care tool to provide for simple acute self-limited conditions, provide access for people to get web-based treatment for sinusitis, potential UTIs, vaginitis in women, and things like that. So we're trying a number of different approaches to see which work best for which populations to really move that experience bar for people. And so the Archimedes Indigo pilot is, I'm just going to go back here, is it's being tested right now in 2 of our 40 practices. So it's being tested in a very busy family practice clinic kind of on the edge of the main metro area in Minneapolis. And it's being tested in a clinic that was one of our original pilot sites as we did our care model innovation. So they're very comfortable with taking on new technologies, offering really good feedback, really used to experimenting to figure out how a tool like this can work into patient flow and into the workflows in the clinical practice. And then we're also testing it in one of our largest internal medicine practices. And no offense to them, but they're a little stodgier and a little less likely to want to change their practice. And so we really wanted to get their buy-in and make sure that this would be a tool that would work. And frankly, because they're internists, they have sicker patients, and so it really helps us test this against their the greater incidence of diabetes and hypertension and CV risk factors that they have in their practice. The results today have been very interesting. We don't have any kind of utilization impact and such at this point, but 2 surprising observations for me are that many of our internists especially are using the Indigo output as a check on themselves to see how well they've been doing in managing their patients. So they get it available on every patient that they're seeing if it's applicable, if they've got the need for the cancer screening on the tabs that Pete showed, or if they have diabetes or diabetes risk factors or CV stroke risk factors. But they often have been using it to test themselves to see, am I taking as good a care of my patient as I thought I was? Soberingly for them, the answer often is not, and then they're using the sheet in the output with the patients as they begin to have conversations about adding additional medications or reintroducing topics like smoking cessation, exercise, weight loss, and the such. The family practice clinic on the northern side where we're piloting it, the surprising learning from them has been they use it all the time, and they don't see it as a check on themselves. They really see it as a tool that they're using with their patients to engage in shared decision making. But the other place that they immediately saw an opportunity to use it, which was not obvious to me, is they have a PharmD medication therapy manager assigned to their practice part-time. And that MTM pharmacist uses it with every patient that they see. And they have found it's been very successful in helping them quantify for patients why they would make certain recommendations for them in terms of adjusting blood pressure, diabetes, statin level doses, et cetera. So while we were originally seeing this as a tool for the doctors to use, this practice immediately saw it as an opportunity for an allied professional in their practice to use. And then also, one of them has been experimenting by asking the nurse or the MA as they room the patient to sort of pull up the Indigo results and suggest to the patient, based on what the bar graph looks like, say, just want you to be prepared that, I'll pick on Dr. Peters, that Dr. Peters will probably want to talk to you about raising the dose of your Lipitor today. And so they're able to plant seeds with patients prior to the doctor getting there, so there can be, whatever pre-contemplation, contemplation, et cetera, stages of change may need to occur. It gets the patient engaged and begin to think about what may be other aspects of the conversation that will be going on. And then lastly, that clinic is just put together a proposal that they would like to hire a health coach to embed within their practice. And part of their justification for the position was that by using the Indigo output, they can use them for the tobacco cessation, exercise, weight loss strategies, and again, give them a leg up with the quantitative information as they're working with patients. I'm looking at the question here really quickly. I see that someone asked, would I be able to contrast this system with the more traditional registry? I will try to address that in a minute in terms of our C3PO work, but I'll also let Pete type in a response if he's got one as well. So further ideas that we've been contemplating as a medical group has been to sort of see what we can find with gaming technology. We have a group of pediatric endocrinologists using some gaming technology right now to manage their type 1 diabetic kids, but we're interested to see how we can extend that into adults with diabetes and such. We're experimenting with some social media attributes, trying to see where we can use technology to speed in what is often a frustratingly slow check-in process, as well as a pre-visit symptom checker, if you will, for people with EPIC or loading their history in prior to their visits. And then we're also sort of, when we really kind of get waxing philosophical and have a beer or two in our systems on Friday afternoons, begin to think about what the power could be to tie sort of a Watson-like ability to help doctors make diagnoses or think about further diagnostic interventions with an Indigo tool helping to engage patients and changing their behaviors and such, and what the combined potential and possibilities might be there. So I described how we're using Indigo at Fairview, the different clinics that we've got it rolled out, and we've got it with 18 providers right now. And with the care model innovation work that we did a couple of years ago and rolled out through our clinics, a lot of the focus of the pilot isn't, we don't need to test the mathematical model. We trust the people at Archimedes that they've done that right. It's really been, how can we build this into our workflows? How can we make sure it doesn't slow us down, but really enhance the conversations and the interactions that we have with our patients, and then figure out where we can go from there. And then lastly is we'll be engaging later this spring as we understand the impact that this has had, particularly the risk score I'm really curious to see how we can demonstrate, for example, that our Oxborough clinic will have dropped its risk score. I'll make these numbers up from 1,000 to 750. How we can translate that with people at Minnesota Community Measurement and begin to make sure that additional credit is received by Fairview and my clinics for providing this additional level of quality delivery to people. And the people at Minnesota Community Measurement realize the limitations of treating quality clinical changes as pass-fail. So this is the many different points that we're using as we go through this pilot with Archimedes and Indigo to evaluate sort of the role that it can play with us. Part of it's just, some overall process work. How many patients are receiving their statistics, and what's the risk score and the benefit for those patients? What are the summary statistics? Are we seeing a change in prescription usage from baseline based on the recommendation of Indigo to adjust or add medications? And what's the adherence that's like? Are we seeing the predicted risk changes from the baseline? Some estimates of our averted events. And this is really important for me, just because of my approach to quality improvement, but also for some of our key constituencies. Because while the numbers are nice, and it's very nice to be able to state that our best performing clinic has 59% of its diabetics achieving optimal diabetes care. It also helps for us to be able to talk about, based on the number of diabetics in that clinic, that there are X number of people walking around in that small town with both legs because of the vascular complications that we've been able to prevent because of our improved work there. Or there's more people with both eyes, or that can see, or that are not on dialysis, et cetera. So we want to be able to tell what we hope is a richer, more emotional story than just the cut and dried data reports that are useful for many audiences, but not for all. We also want to make sure that patient satisfaction is either not being impaired or to get a sense for how it's being improved by having richer conversations and some more quantitative but nicely presented graphic information about benefits they can anticipate from making suggested changes. We want to make sure as well that our providers and staff are satisfied with the work, that it's not slowing them down or interfering with their work or their interactions in the exam room. And then lastly, I mentioned that we have these sort of team-based conferences called C3PO, Chronic Care Condition Provider Overview Conferences. And one of the things we're testing right now is how can we use the Archimedes output as an input for that process so that we can use it to either triage people with the greatest risk scores or the greatest benefit scores based on the various interventions and whatnot, so that we can make sure that we're triaging and using this expensive and valuable time to reach the patients who are most vulnerable and who would have the most benefit from those interventions. I'm just trying to... I can't advance the slides anymore. Sophia, is this our last one? I apologize for not remembering. It might be.
I think it is. I think it is your last slide.
Okay. Well, I'm going to, I think I will pass the ball back to Pete. I see that he has got an answer to, I think it's Nermeen Iskander's question. And then I'll be available till 1:30 your time for any questions that people might have about how the work we've done with us or how it's working. Thank you.
But Patrick, have you used traditional kind of chronic disease registry population approaches in your clinic prior to using Indigo?
Only the C3PO conferences, which we pull out of Epic. But prior to that being started in our clinics, which would have been in just about a year ago, we didn't traditionally have any formal process or expectation of using registries. Some of our physicians were using it, but wasn't an expectation that would be part of the practice.
Okay. Maybe, Pete, you could speak a little bit more to the Kaiser experience, because they had been using chronic disease registries for some time.
Sure.
I'm passing the ball back to Pete. I guess I don't need to pass it, do I, if we're done with it?
No, you can pass it back to me. Pass it back to me, Patrick.
Okay.
So, so just to answer, I saw Nermeen's question, and I think it's a great question. Really, the Indigo tool is, in some ways, very different than and complementary to a traditional registry system. What the Indigo tool does is provide analytics and allow you to take the patients that exist inside of your registry and really rank them more finely at a more granular level. So in a traditional registry, you can, and certainly in how it was had been implemented during our Kaiser pilot, was they had a registry tool that they had been using, and they still do use. It's a very well-developed and excellent tool that they use to keep track of their patients, and the physicians really use it in the normal course of their patient care. And what we did is we sort of added a new variable or a new field into that registry, which gave them some new information. And so if you think about a registry that has an embedded gap analysis allowing you to identify patients who need this intervention on this guideline or maybe missing a foot check or so on and so forth, our tool allows you to sort of rank your patients within that registry and then go after the ones who may have the most available benefit. So, you know, inside a registry tool, really what you get is a lot of binary information, and this patient is or is not, you know, eligible for this or this not test, or they need to have this visit or not. And what our tool can help you do is really, you know, rank those patients inside of the registry so that you can go after the ones who we would estimate to have the most available benefit, and looking at it from a different perspective. So, I think that the Indigo tool and analytic tools like this are complementary to those registry systems, but our tools are really dependent on, you know, having an underlying data infrastructure that allows us to run our analytics. We need the fuel for the algorithms, and those are things like electronic health records or other data marts or health information data exchanges that people may have put together.
So, Nermeen, do you see Nermeen's questions, Pete?
I do see Nermeen's question. Is people use, so they've used it in a variety of ways. To be totally honest, so it's really been in a combined way, both with an EHR and in a registry. I think that it really depends on how you want to implement the tool. It also depends on the workflow at your particular site. If you don't have an EHR but you have a registry tool that's been built, we can integrate Indigo into that tool. If you don't have a registry but you have an EHR, because a lot of EHRs, of course, don't have well-developed population management tools, you can use our tool directly like that. My personal, you know, my personal interest is, of course, in population health, and so I'm excited about all of it, but that's the one that has sort of a special place for me, because I think a tool like this to be able to really guide the care of populations is really, really where I think you're going to get just a tremendous amount of benefit. And certainly in California, with a lot of the, you know, being ahead of the curve, just like Minnesota, as compared to the rest of the country, I think we have a rich infrastructure for that sort of implementation.
Patrick, there was another question earlier asking you about how you see the Indigo work, and I assume also the EPIC work, as integrating with the meaningful use incentives, and whether or not that has a role in getting your providers to actually adopt the technology.
Oh boy, I'm not an expert on meaningful use, and all of our EPIC is our only EHR, and part of our other work that we did with our care model redesign was an expectation that there would be an after-visit summary, for example, with all of our, with every visit, and that there would be, and you know, the e-prescribing and such has been part of sort of the work here, because we have a pharmacy system, if you will, retail and other pharmacies as part of our work. So I don't know that it would necessarily assist us, because from what I can tell from a high level when I'm in our leadership meetings, that we're doing very well along those processes and such. So I can't comment on that well. I don't know if Pete has any further thoughts about that.
You know, it's a really interesting question, Patrick, and I think it was Russ Mitchell who submitted this question. The reason it's subtle is that if we look at the groups that we've had the most interest in, who've had the most interest in Indigo, most of the inquiries about our tool, most of the groups that we're that we've started with, and certainly all the ones that we started with and the groups that we're currently sort of working on implementations for, are groups that hold some sort, manage risk in some way. And because I think, as you think about the sort of transformation of a medical practice from the solo mom and pop, which is of course increasingly rare, all the way to the very large integrated delivery system like a Kaiser Permanente, or groups that exist in Group Health or health partners in Minnesota and Fairview, et cetera. What you're seeing is that you don't even have a real opportunity to think about tools like this until you've gotten a lot of those sort of other issues out of the way. And I think from a meaningful use perspective, certainly a tool like ours is, and I'm not an expert on meaningful use either, is the kind of thing that groups like the ONC are thinking about in terms of these are the tools that they'd love to see implement. Tools like this are things they'd like to see implemented, nationwide. But I really think that you're going to get most of the drivers in the short to medium term with groups that hold risk or have some reason, some incentive, either on pay for performance or quality metrics, et cetera, to have a tool like this. I think it's going to be the rare single group or two group practice in a place where they're not heavily involved in or integrated care that they're going to implement a tool like this. We are certainly excited to be able to do that, but I think that's not where most of the bulk of the interest is going to come.
Great. And then you see this question from Kate Caldwell about whether or not the Indigo tool can create other types of aggregate population and audit reports.
So no, I hadn't, because I had scrolled up to see to refresh myself with the previous question. You actually can use Indigo to do that. And so what I showed so Indigo is that I've demonstrated and showed the screenshots for, and that Patrick and his group in Fairview are implementing, is this user interface that's specific to a physician visit. We are working on tools that allow us, that are going to create population management tools and reports to be able to generate that. That's sort of in its infancy right now. All the algorithms exist. So the tool itself has all the algorithms, and it's really just a matter of us doing a query and creating sort of almost an Excel spreadsheet-like output of it. But we are thinking about inside of Archimedes for our future product development to be able to create a population tool itself that would be more sort of scalably available. But we're just in the infancy of that, and if there's demand, we're certainly excited to make it. And so yes, you could skip the step of buying a registry, or certainly help you think a little bit harder about what you want in your registry.
Yeah, we certainly at Fairview didn't we didn't own a registry before we adopted the Archimedes work.
Mm-hmm. And yes, Kate, I agree. It is super important. It's really the thing I'm most excited. It's really the thing I'm most excited about, and why I stay in touch with Sophia, because it's the most exciting stuff we do.
So I'm going to give folks another few seconds here to type in another question, but this has been an absolutely fabulous webinar, Pete and Patrick, and so thank you so much for your time and for sharing what you're doing and your experiences. I want to let everyone know that, hopefully you can see from the slide on the screen, we will be posting today's webinar slides and the recording from today on our website, and I'll work with Pete to include those additional references on the Archimedes model in that slide set so that it's available to everyone. So I think on that note, I get to say thank you to our speakers, thank you to our audience, and we hope that you will be able to join us. Our next call, actually I should have the date in front of me, is the fourth Thursday in February, Wednesday, excuse me, in February, which will be February 22nd, same time, 12:30 p.m. Pacific, and we will be talking then about practice coaching. And so I hope for those of you who are interested that you'll join us for that call. Thank you, everyone.
Thanks so much.
Thank you.
Bye-bye.